You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for February 12th, 2021. This week, COVID, the prefix pre before a condition, AI and mobile ECGs, heart failure with preserved ejection fraction, and statins. First, a brief note on COVID. The Johns Hopkins site again reveals plummeting cases. Plus, millions are receiving vaccines that are nearly 100% effective. And our COVID census in our hospital, like so many other hospitals, is decreasing. I've read the details on the virus variants and I understand the caution. But gosh, we've had so much caution. Perhaps some optimism is in order. Morose messaging fails in the cardiology clinic. It'll likely fail in the public sphere too, especially now. First topic today is pre-diabetes. Now, last week I led the podcast with the limits of screening for asymptomatic disease in the carotid arteries. This week I'm going to lead on the limits of the label pre before diabetes in older adults. Now, this pre-diabetes is also found from screening people with no complaints. Before I get to the JAMA internal medicine study, let's set out that hospitals and clinicians have enough manifest disease to treat without creating extra categories for those at risk for a condition like prediabetes or, a few years ago, prehypertension. For instance, did you all know that the AHA and ACC codify something called Stage A heart failure? Now, I wouldn't want to have Stage A heart failure. It sounds bad, but here is its description. You have Stage A heart failure if you are, quote, at risk for heart failure, but without structural heart disease or symptoms of heart failure. Preconditioned states like this are nuts. I mean, not dying at a young age puts you at risk of heart failure and hypertension and diabetes and cancer and falls and dementia and yes, even COVID. Okay, now to the timely and worthy study. PI Dr. Mary Rooney from Johns Hopkins and colleagues used data from the ERIC longitudinal study to look into the risk of progression from prediabetes to diabetes in older adults. Now recall that ERIC is one of those population-based studies like Framingham that follow patients over time. The study included about 3,400 older-aged people without diabetes. The authors used categories to define prediabetes by either hemoglobin A1C or impaired fasting glucose or both. Individuals were followed for over 6.5 years, and the primary endpoint was developing overt diabetes, again defined by hemoglobin A1C or a glucose-lowering medicine, or again fasting glucose. Now, the findings were that the prevalence of prediabetes in these 3,400 patients ranged from about 30% to 65%, depending on the definition used. Bottom line, there was a lot of prediabetes. Among those participants with prediabetes defined by the hemoglobin A1C only, 9% progressed to diabetes, 13% regressed to normal glycemia, and 19% died. And similar patterns were seen in the other categories of prediabetes. In other words, older adults in this fairly representative cohort had a small chance of progressing to true diabetes, and in fact, there was a higher risk of regressing to normal than progressing, and a more than double chance of dying than progressing to diabetes. The authors humbly conclude that prediabetes may not be a robust diagnostic entity in older age. This is an understatement. First of all, as highlighted by the editorialist, even overt type 2 diabetes in older adults could be considered a risk factor, not a disease. Prediabetes, therefore, is a risk factor for a risk factor. And again, as I've said, being alive is a risk factor. Prediabetes in this study was more likely to regress than progress. So the specific translation of this study and others like it are to A, recognize that for older adults with limited life expectancy, prediabetes is irrelevant. B, to consider placing less emphasis on these numbers in healthier older adults. And C, we should revisit the value of prediabetes in middle-aged adults. We should all be thankful for JAMA Internal Medicine, as they are the journal that most often publishes studies that force us to think about overdiagnosis and overtreatment. And I'll close this topic with a quote from Aldous Huxley, who wrote, quote, "Medical science has made such tremendous progress that there is hardly a healthy human left. Let's stop this sort of madness." Okay, next topic is mobile QT interval measurement. The Mayo Clinic group is doing incredible work in applying artificial intelligence to ECG interpretation, not only on standard 12-lead ECGs, but also with these smartphone-enabled ECGs that more and more people have. Now, I'm on record of being skeptical of many things about digital health, but I see some potential in training machines to help us read ECGs. Before I tell you about their interesting paper, two background items are notable. First, remember, while we mostly reserve ICDs for patients with low ejection fraction, the vast majority of sudden cardiac death in absolute terms occurs in people with ejection fractions better than 30 to 35%. That's because there are far more people with good EFs than bad EFs. The second important background item is that we know that things that push the QTc above 500 milliseconds, things like genetics and drugs and hypokalemia, cancer, even COVID-19, these are pro-mortality indicators. Now, the important caveat to this rule has two important exceptions. Amiodarone and V-pacing are two QT prolonging factors that do not increase the risk of VT. Now to the study. The Mayo group used 1.6 million standard 12-lead ECGs from more than 500,000 patients seen there to derive a deep neural network, a DNN. Recall that typical machine learning separates big data into a training, testing, and validation subsets, which the authors did. They then compared the DNN system of reading to cardiologist overread as the gold standard. So the ability of the deep neural network to detect clinically relevant QTc prolongation, that is, a QTc greater than 500, was then tested prospectively on about 700 genetic heart disease patients. Now, half of these had long QT syndrome. They used testing with both the QTc values obtained from the 12-lead and from a mobile ECG equivalent to the commercially available AliveCor or CardioMobile 6-lead. Now, in the validation sample, they saw strong agreement between human overread and DNN predicted QTc values. The authors called these nominal differences. And then, in the group of patients seen in the genetic clinic, again, the DNN predicted QTc values from the mobile ECG were similar to those read from a 12-lead by both a QT expert and a commercial core laboratory. And when applied to the mobile ECG tracings, the DNN's ability to detect a QTc greater than 500 milliseconds yielded an area under the curve sensitivity and specificity of 0.97, 80%, and 95% respectively. Those are pretty good numbers. The first thing to say is that you should read both the paper and Steve Stiles' incredible coverage. His is a great piece. Steve gets relevant comments from both the senior author, an enthusiast, and a neutral observer. I also reached out to Dr. Ackerman, the senior investigator, by email. And before I tell you what he said, I will admit a bias. I really like Dr. Ackerman. I've been bugging the heck out of him for more than a decade about clinical long QT questions. And he's always been prompt and generous and helpful. He's been a great teacher to me, just clinically. Okay, it's fair to say that Professor Ackerman is an enthusiastic supporter of this. He wrote, "We think this is going to be a total game changer. Once FDA clearance is provided, we'll be in a position to be able to readily obtain an accurate QTc without a 12-lead ECG as a true vital sign." Now, in the paper, they propose futuristic things like doing a spot check in pharmacies when a patient is given a strong QT prolonging drug. Also, what about psychiatry? Many of the drugs they use are QT prolongers, and getting a good QTC without having to go through the whole process of getting a formal 12 lead might be extremely valuable. I also thought about use of the mobile ECG and QTC measurement in a methadone clinic. That might be an application. Now, one obvious large limitation of this technology would be in the realm of screening low-risk populations. Now, keep in mind they tested it in a population enriched with long QT patients. The problem with screening is, again, Bayes' theorem. Recall that medical tests, like a QTC measurement, don't tell you if you have a disease. It just updates your prior probability. By the way, it's the same concept with clinical trials. Let's say you're not at Mayo Clinic and your population has only a 1% incidence of long QT syndrome. That is the prior, and 1% is probably high for a general population. Bayes' theorem calls for multiplying the prior, or the prevalence of the condition, by the likelihood ratio from the test to get the chance of having the problem if your test is positive. Now, the likelihood ratio here is the chance of having a positive test, the sensitivity, divided by the false positive rate, or 1 minus the specificity. So the DNN-enabled ECG sensitivity is 70%, the specificity is 95%, which sounds good, right? So you divide 70% by 5%, you get an odds ratio of 14. That also sounds good. In other words, with these characteristics, the DNN-enabled mobile ECG would update your 1% probability of having long QT by 14 to about 0.14 odds, or a 12% probability. You see the problem. More than 85 out of 100 patients tested, in this case, would be false positives. Dr. Ackerman agreed that specificity needs to improve before widespread screening, but he also noted that a positive predictive value of 10 to 20% isn't too shabby. That is, he wrote, "It is precisely the overall positive predictive value of ECG screening programs right now. In other words, anytime an athlete ECG flags an athlete with an ECG foul, we should be lifting up the penalty flag about 80 to 90% of the time." So I may be wrong, but I have a similar feeling about this whole AI and ECG thing as my initial thoughts on CRT when someone first asked me many, many years ago whether putting an LV lead in the CS could reverse left bundle branch block and improve heart failure. I said at that time, laugh out loud, that would never work. So I was totally wrong. In other words, being pessimistic here about AI might also be the wrong take. Next topic is heart failure with preserved ejection fraction. Another RCT in heart failure with preserved ejection fraction has been published, this one by JAMA. Before I even tell you what the trial tested or what the results were, you can use Bayes' theorem to predict the outcome. Your prior in this condition is extremely pessimistic because no trial of many has delivered a statistically significant overall primary endpoint. So, if you are multiplying, say, 99 to 1 odds of a null hypothesis times even a very good result from the trial, your outcome is likely to still be null. Do it in your head. 99 times 0.05 is equal to 5, or an 83% probability of the null. By the way, my wife Stacy uses Bayes to predict my chance of closing cabinets or my bureau drawers, and she too has pessimistic priors. Indeed, this 3-arm RCT of high-intensity exercise versus moderate-intensity continuous exercise versus standard recommendations for physical activity, done in 5 centers in Europe in 180 highly selected patients with heart failure with preserved ejection fraction, failed to show a statistically significant difference in the primary endpoint of change in peak VO2. What's more, there were no major differences between these groups in things like BNP or diastolic parameters or KCCQ quality of life questions. Please do read Patrice Wendling's excellent news coverage. And as an exerciser and advocate for high-intensity exercise, this is disappointing. The investigators set the stage for a good outcome. They screened more than 500 patients and enrolled 180 presumably motivated patients. They measured a highly relevant primary outcome. I like VO2 max because it quantifies exercise tolerance. They enrolled representative patients. These were 70% women, age about 70, BMI 30, a good mix of comorbid conditions, and not even a tiny signal of benefit. I mean, when you look at figure 2, it's hard to see that there's going to be a type 2 error, false negative. It seems unlikely. Now, I know what you may be thinking. You say, come on, Mandrola, despite telemedicine support, only about a half of the patients performed at least 70% of the prescribed training sessions during home-based exercise training. Now, my answer to that criticism is that this is part of the deal with exercise or diet interventions. Part of it is the physiologic effects, right, the exercise, and the other part is the adherence. It's a classic example of why intention to treat is so important. It's like if you had a wonder drug that delivered these huge benefits, but a third of the people couldn't take it because it burned their esophagus, it wouldn't be a very good drug. That said, I still think we can tell our patients with heart failure with preserved ejection fraction to be as active as possible. Walking and regular exercise is always a wise prescription. And I still hold out some hope that the SGLT2 inhibitor class will be beneficial in this group of patients. We shall see. The final topic today is observational study follies. Now, I mention this study only for its lesson in why we should either ignore or be very cautious with observational studies. A group of well-meaning authors looked back retrospectively using 2 data sets at patients who had adhesion-related abdominal issues. They found that statin use associated with a 19% reduction in one data set and an 8% reduction in the other data set. Now, they did all the usual corrections and adjustments that you do with a non-randomized study to try and simulate randomization. But then the JAMA Network Open reviewers and editors let them have this concluding sentence, quote, "Statins may represent an inexpensive, well-tolerated pharmacologic option for preventing abdominal-related complications." My friends, this is awful. You simply cannot make these sorts of highly improbable causal claims that statins reduce adhesions without a proper randomized trial. The decision to use the statin in the first place must be random, and then you can assess adhesion complications as a primary endpoint. There are many, many good reasons to take a statin. Reduction of cardiac events, but reduction of adhesion lesions is not one of them. What's more, let's do a fantasy exercise and let's just pretend that these results were true. It's likely not true, but it's a great exercise in looking at absolute risk reduction. Okay, here it goes. The total event rate in one of the data sets was 1.4%. The statistically significant 19% relative reduction would reduce events, therefore, by 0.26%. So instead of a 1.4% risk of an adhesion, you'd have about a 1.1 risk of an adhesion. The total event rate in the other data set was 4.6%, and the 8% relative risk reduction would lead to a 0.37% reduction. So instead of having a 4.6% rate of adhesions, you'd have a 4.2 risk of an adhesion. I mean, these are tiny, insignificant differences. I understand why papers like this get done. Publications are the currency of academics, and I understand why papers like this get published. It has statins in the title and it will likely get attention. What I cannot understand is how referees and editors let the authors use causal languages in these papers. This causes me great stress. Now, there was another Howler coffee observational study this week, but I'm just too tired to beat that one up as well. Next week, I'm going to review the big semaglutide and weight loss paper that was published in New England Journal of Medicine. And that's it for this week in cardiology. As always, I'm grateful that you listened. And remember, if you like this podcast, please take the time to give us a rating or even writing us a 1 or 2 sentence review, as that helps others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.